So we'll discuss about SDH meningeal embolization with medial meningeal artery. So starting with the case, 74-year male, diabetes, hypertension, coronary artery disease, and recurrent stroke on DAPT. So he has very high risk factor for coronary artery disease as well as stroke, and present with the headache, confusion, and urinary incontinence, and there was a mild head injury 15 days back, and you can see there is a small subdural hematoma, but there is a significant compression, and this ventricle is not visible on the left side. And he was high risk patient. In that sense, patient have coronary artery disease and recurrent stroke and DAPT. So stopping DAPT and subjecting to surgery was the challenge. So surgeons asked to take up. So this is the angiogram, and right common carotid artery shows occlusion of the internal carotid artery, and the left common carotid also show occlusion. So there was a bilateral IC occlusion in this case, and this patient had RD, recurrent stroke. This is right common carotid artery injection, and you can see there is no flow in the internal carotid artery on the right side. This is the middle meningeal artery, and what we can see, there is a filling of the ophthalmic artery from here, and there is an anterior segment, and this is a falcine artery. So this area does not seem very healthy here for point of embolization, because if you want to do middle meningeal artery embolization, then definitely ophthalmic artery is there, falcine artery is there, and definitely the embolization will be very risky with patient with a bilateral carotid occlusion. This is the left common carotid artery. Again, there is no filling of the internal carotid artery, but you can see there is a filling of the distal segment of the internal carotid artery, and you can see filling of the anterior cerebral artery. You cannot see the filling of the middle cerebral artery. There is a reconstitution of the internal carotid artery to the external carotid artery branches. Possibly it is a ascending pharyngeal artery, which is reconstituting to the distal segment of the internal carotid artery. This is the vertebral artery injection, and now this is vertebral artery. You can see there is a predominantly giving the pica and very small basal artery. But this small basal artery has to supply whole of the anterior circulation. So you can see there is a filling of the MCA of the both side, filling of the left side, the ACA from this side. So this small artery, basal artery, has to supply whole circulation. So we will learn SDH middle meningeal artery embolization along following headings: anatomy of middle meningeal artery and its blood supply, anatomic variation in the middle meningeal artery, dangerous anastomosis of middle meningeal artery, safety point in middle meningeal artery embolization, and what are the mechanisms involved in the development of chronic SDH. Middle meningeal artery, one of the largest branch of external carotid artery, and is a major human dural artery. So most of the dura is supplied by the middle meningeal artery, and is supplied the 2/3 of the cranial dura. So intermedullary artery, from first segment of the intermedullary artery, the middle meningeal artery arises, and it passes to the foramen spinosum and become intracranially. Middle meningeal artery has various anatomic variations. Origin and course may vary, and its relation to ICA is very, very important, because it has connections with the ophthalmic artery, inferior trunk, and the trigeminal artery. So this is the middle meningeal artery. Here it has connection with the ophthalmic artery, it has connection with the inferior trunk, and it has connection with the trigeminal artery system. So I will tell only one slide of middle meningeal artery, that usually it is a third arch which gives the stapedial artery, and this stapedial artery initially arises from the internal carotid artery. So there is the internal carotid artery which is giving supply to the stapedial artery, but stapedial artery will, at the 10th week of the development, this stapedial artery will degenerate, and this stapedial artery ultimately gives to the middle meningeal artery. So, and it becomes part of the external carotid system. So initially it was part of the internal carotid system, and then it becomes part of the external carotid system. That's why there is a lot of collaterals between ICA and ECA through the middle meningeal artery. This was shown by Dr. Deep yesterday. So middle meningeal artery has various variations. The middle meningeal artery can arise from the ophthalmic artery in 0.5% of cases. These are the different type of origin of the ophthalmic artery, origin of the middle meningeal artery. So middle meningeal artery arises completely from the ophthalmic artery. In that case, the foramen spinosum can be absent. Partial ophthalmic artery origin of the middle meningeal artery. So anterior division arises from the ophthalmic artery, and posterior division remains as a branch of the intermedullary artery. Here the foramen spinosum side is reduced, and sometimes the ophthalmic artery origin of the accessory meningeal artery, where the foramen spinosum become normal. So this is the case where the middle meningeal artery is completely arising from the ophthalmic artery. Here the middle meningeal is partially arising from the ophthalmic artery, but it is also arising from the external carotid artery. And another variant which is very important to identify, particularly when you are planning for middle meningeal artery embolization, is the meningolectrymal variant. So here you can see there is no ophthalmic artery when you take internal carotid injection. This is the external carotid artery injection, and now you can identify this is a choroid blast. So this choroid blast is from the middle meningeal artery, which is arising from the external carotid artery system, and there is no ophthalmic artery or choroid blast from the internal carotid artery injection. But the problem is sometimes this choroid blast is not seen before MMA embolization. So you have to be very, very careful when you are embolizing through the middle meningeal artery that choroid blast is seen or not. So these are the various branches. There are the four major branches of the middle meningeal artery. So this is extracranial part. Here it enters with the foramen spinosum and become intracranially. So this is called basal part. Then you have two major divisions. This is anterior division and this is posterior division. So this is the bifurcation at pterygium region, and it becomes anterior and the posterior division. These anterior posterior divisions are draped across the dura mater, and these are the mainly used for the embolization of the middle meningeal artery. There are some minor branches. The minor branches are from the petrous segment. So these are the small branches of the middle meningeal artery from the petrous segment. These are the petrous segment branches. There are some branches from the cavernous segment, and there are some branches from the sphenoid segment. So this is the DSA, and this is the middle meningeal artery. This is the first branch, it is petrosal branch. This is the posterior division, this is the anterior division, and this posterior division given petrosquamous branch and parieto-occipital branch. This is about the anterior division of middle meningeal artery. So this is the anterior division, and it is the Falcine artery branch. It is very important to identify this Falcine branch because it anastomosis with the ophthalmic artery, and then it can be sometimes from the dangerous anastomosis. The another important thing of the anterior division of the middle meningeal artery that it crosses midline and go to the contralateral side. So some advocate that you have to embolize from both middle meningeal artery. In spite of the hematoma is one side, we have to do embolization from the both middle meningeal artery because it crosses to the contralateral side. So coming to the posterior division had petrosquamous branch and the parieto-occipital branch, and this branch division of the middle meningeal artery anastomosis with the all the posterior branches of ECA. There is occipital artery, ascending pharyngeal artery, but at the same time it also anastomosis with the subarcuate branches of ICA and posterior meningeal artery of the vertebral artery. So these are the all connections of the dural branch posterior division of the dural artery, and so you have to be very careful even with these anastomotic channels. So as I told that middle meningeal artery supplies most of the dural convexity. It supplies the falx cerebri also, and this anterior part or the frontal part of the dura is supplied by the ophthalmic artery, and the posterior part of the dura or occipitomedial dura is supplied by the vertebral artery. So most of the supply is from the middle meningeal artery, the anterior part is from the ophthalmic artery, and the posterior part is to the posterior meningeal artery from the vertebral artery. Even the dura mater of the sagittal sinus is supplied by the middle meningeal artery. The trochlea is supplied by the middle meningeal artery. Then it mainly supplies the middle cranial fossa, but it also supplies the lateral part of the anterior cranial fossa and inferior part of the lateral part of the cavernous sinus. It also supplies dura of the cerebral fossa And this posterior fossa dura is in balance with the ascending pharyngeal artery and occipital artery. So this is the large dural supply of the middle meningeal artery. So these are the various branches of middle meningeal artery, and it's important to know some of the branches because it has supply to the cranial nerve as well as it has some dangerous anastomosis. So one is the petrosal branch, which is the first branch. It's supplied to the trigeminal ganglia. So it is a supply to the fifth cranial nerve, and it has anastomosis with the ascending pharyngeal artery. So fifth cranial nerve is supplied by the petrosal branch of the middle meningeal artery. Then superior tympanic artery supplies the geniculate ganglia. So the seventh nerve is also supplied by the middle meningeal artery. So fifth and seventh, these cranial nerve are supplied by the middle meningeal artery, and particularly when you are planning to embolize, you have to be careful that sometimes you may develop seventh nerve palsy or fifth nerve palsy. Then the cavernous branch communicate with the inferior lateral trunk of the internal carotid artery. The anterior division or frontal branch communicate with the anterior and posterior ethmoid artery and contralateral middle meningeal artery. Falcine artery, front side branch of the middle meningeal artery, communicate with the anterior falcine artery of the ophthalmic artery. Then the petrosquamous branch, the posterior division, communicate with the ascending pharyngeal artery, and the parieto-occipital branch of posterior division communicate with the posterior meningeal artery. So it has a lot of anastomosis, and you have to be careful when you are planning for embolization, and it has supplied to the fifth and seventh cranial nerve. So the trigeminal and facial nerves are supplied by the petrosal branch of the middle meningeal artery, mainly the Gesserian ganglia and the geniculate ganglia. But facial nerve has supplied by the multiple blood vessels. So this is the middle meningeal artery, and this is the petrosal artery, which is supplying to the geniculate ganglia. But this geniculate ganglia is also supplied by the posterior auricular artery. Posterior auricular artery is stylomastoid branch of the occipital artery, facial artery, and as well as by the ICA. So it has very rich supply from the various segments. We know that ICA supply the seventh and eighth cranial nerve. There is a lot of anastomotic channel, but these three channels are very important. So there are three major anastomotic regions of the vascular anastomosis. One is orbital region, another is petrocavernous region, and third is posterior fossa. So we have to take care of all these anastomosis when we are planning for embolization. So in the orbital region, this is the orbital region, and this is ophthalmic artery, this is the middle meningeal artery, and this is supply the communicating with the ophthalmic artery, anterior division. So it has communication with the recurrent meningeal artery, and it has communication with the lacrimal artery via meningo-lacrimal branch. Then this is the middle meningeal artery, petrocavernous segment, and it is mainly communicate with the inferior lateral trunk, but it also have anastomosis with the meningo-hypophyseal trunk. Then posterior fossa, the petrous and parieto-occipital branch. So this is the posterior fossa, this is the middle meningeal artery, parieto-occipital branch, and it is have communication with the occipital artery branches and the ascending pharyngeal artery branches. So the most dangerous anastomosis we have to remember is ophthalmic and inferior lateral trunk. So this is the communication with the inferior lateral trunk, and this is communication with the ophthalmic artery. So these are the most dangerous anomalies when you are planning for embolization. And transarterial embolization definitely pose a risk to these vessels. So what is the safety point for embolization? Not to embolize from the position proximal or near the foramen spinosum. So this is the foramen spinosum. So if there is no large meningo-lacrimal trunk, we can embolize up to here, but we should not go below here because the geniculate and Gesserian ganglia are supplied here. So we can sometimes compromise the artery up to here, but we should not go around the foramen spinosum or below that. And second thing, we must remember there should not be meningo-lacrimal variant. Like in this case, this is supplied the ophthalmic area. And usually the particles are safer than the liquid embolic agent as far as cranial nerves are concerned. So why patient have subdural hematoma? It is occur because of the injury of the bridging vein. What is the bridging vein? Bridging vein is a connection between sinus and the cortical vein. So it is maybe the superior sagittal sinus, it is a cortical vein. So the vein connecting sinus to the cortical vein is called bridging vein. So this bridging vein injury may produce the chronic subdural hematoma. The standard treatment is Prabaho lubrication. So why we are doing medial meningeal artery embolization? Because medial meningeal artery represents the principal blood supply to the bleeding membrane, and occlusion allows collection to be reabsorbed. So along hematoma, there is a formation of membrane, and this membrane is supplied by the medial meningeal artery. So that's why the endovascular MMA embolization came in concept. So when there is a subdural hematoma, there is a chain of reactions. So this is a subdural hematoma, and around that there is an external membrane, and this is an internal membrane. And there is a lot of inflammatory response to this hematoma of the residual blood, mainly the interleukins 6 and other factors play a role. Along with it, there is a formation of membrane around the hematoma, and a lot of neoangiogenesis also take place by the various factors, mainly is the VGEF, and other factors also produce the neoangiogenesis. Along with it, these neoangiogenesis vessels are not very stable vessels, they are fragile vessels, and they rupture and they produce the rebleeding phenomena. Along with that, there is an ongoing process of fibrinolysis, and this fibrinolysis produces ongoing hemorrhage. So SDH is not one-time phenomena. There may be fibrinolysis and there may be ongoing hemorrhage. Along with it, there is a neoangiogenesis, fragile vessels, and these fragile vessels may rupture, and there may be recurrent SDH in around 20 to 30% of cases. So this is the proposed treatment algorithm for the chronic SDH embolization. Chronic SDH, if it is asymptomatic and if it is less than 8 mm, without midline shift, just observe or medical treatment. If asymptomatic, including headache, and if it is more than 8 mm, plus minus midline shift, then you can place the middle meningeal artery embolization. So asymptomatic and more than 8 mm is the indication for middle meningeal artery embolization. But patient is symptomatic or there is a large SDH with midline shift to more than 5 mm, then better to go surgery. Some surgeons prefer to have pre-surgical middle meningeal artery embolization followed by surgery. So what is the indications for the MMA embolization? Most important indication is recurrent chronic SDH. Because after Prabaho lubrication, the rate of recurrence is around 2 to 37%. It is taken around 20 to 30% patients. Even in spite of Prabaho lubrication may have recurrent SDH, and in that case, the middle meningeal artery embolization is indicated. And another group of patients, those who are older and who are anticoagulant and antiplatelet, and it's not feasible to stop anticoagulant or antiplatelet because of recurrent stroke or maybe prosthetic valve, then it is one of the indication for embolization. So coming back to the case, 70-year-old male, diabetic, hypertensive, coronary artery, and we see that both internal carotid artery was completely occluded and it was dependent on only the posterior circulation. So stopping antiplatelet is difficult job in this case, and even surgery is difficult because of the loss of lot of vascular risk factor. So this is the left common carotid artery injection, and we can see there is no flow anterally in the internal carotid artery, but it is reconstituted by the external carotid artery system. And this is left external carotid artery injection. This is middle meningeal artery. Here is the foramen spinosum. This is the posterior division. This is the anterior division. But here there is some danger. Why is it danger? Because the ophthalmic artery has communication here, and this is possibly the falcine artery. So we have danger that how to proceed for the embolization. Because this is the frontal division, and this frontal division has communication with the ethmoid artery and branches of the collateral branches of the middle meningeal artery. So we place our microcatheter here, but it's not safe because here the ophthalmic artery is arising, here the falcine artery is arising. So we have to advance our microcatheter distally. So we can see there's a dangerous anastomosis from the ophthalmic artery here. So we placed our microcatheter from this segment to distally. So now our microcatheter is here. Now there is no filling of the ophthalmic artery or Falcine branches. You can see there is some blus here because of hematoma. So we use particles. Particles was 50 to 150 micron size. Then we went to the posterior division. We can see again there is a blus here. We went more distally. This is the ultimate microcatheter position to place the PVA particles. 50 to 150 micron particles are placed. This is the post embolization. Now the blus has disappeared, and here the Falcine collectors, here the friendly ophthalmic collectors are intact. Only the distal branches are not seen. This is a pre and post embolization. After 3 weeks, the hematoma resolved. Another case, middle meningeal artery embolization is postpartum CVT with subdural hematoma. So as we know that CVT may produce subdural hematoma. It is because of why patient has HDS because of CVT. What is the pathogenesis?
Anticoagulant.
No, it is not because of anticoagulant. At initial presentation, patient has HDS, but definitely it increases after that.
Dural fistula.
No, it is not dural fistula. This is well known that CVT may present as a subdural hematoma. It is well known. It is because of the occlusion of the venous system. There is a more pressure on the breathing vein, and then breathing vein rupture.
Okay.
So even the CVT may present as a subdural hematoma. So 28-year female, postpartum, cesarean section on 9th February. She had a right hemiparesis, lower limb followed by upper limb within 24 hours. Then she has, after 7-8 days, she has generalized tonic-clonic seizures, and she presented to us on 20th. She has persistent headache and decreased sensation, and Jesus was E4, V4, M6. On day 3 of the admission, the Jesus further deteriorated. All routine investigation, coagulation profile, prothrombotic workup, APLA, and ACL antibody was negative. So this is the CT scan, and CT we know. So we can see there is a parasagittal bleed here, and you can see there is no flow in the left transverse sinus. But along with this, you can see very small thin ring of HDS, very small ring. It is retrospectively visible rather than, and there is a occlusion of the left transverse sinus and bleed on the left side. So this is on 15th. On 20th, this hematoma increase, and the slight midline shift. There is an increased size of HDH. This is on 24th. Again, you can see this hematoma, subdural hematoma is increasing, and there is a midline shift. And the patient's sensorium also become deteriorated. So for deteriorating TCS, neurosurgery reference was taken. They advised for the evacuation of hematoma and stoppage of anticoagulant. And now it is difficult situation. We can stop anticoagulant, but patient has CVT. So we thought that yes, we will continue anticoagulant and plan for middle meningeal artery embolization. So we perform DSA, and when we perform the DSA, there is a complete canalization of the left side of the transverse segment sinus. So CVT completely resolved, possibly with anticoagulant. And this is external carotid artery injection. This is the middle meningeal artery. This is the on the AP view. We place our microcatheter in middle meningeal artery. There is no origin of any transverse vessel here, no Falcine artery. So this is AP view. There was no blus. So the point of question is, if there is no blus, do you want to embolize? We discussed and we found that even there is no blus, you can embolize. So we plan for do middle meningeal artery embolization of the frontal branch. So we place the particles for embolization. So middle meningeal artery embolization was done on 26 February. These are the particle size here used the 45 to 150 micron. So this is the pre and post. We can see middle meningeal artery is visible up to the foramen spinosum. Before that it is occluded. So it is safe point. You should not go beyond this foramen spinosum, otherwise you may have canionopathy. Pre-embolization CT, and this is post-embolization CT after 1 month. This is no hematoma or no SDH in this case. And now patient is follow up after 7-8 months. She is walking now. And with anticoagulant, this is the before anticoagulation, and this is after 10 days of anticoagulation. There is a very good decolonization of the venous system. Another case of traumatic chronic SDH in 75-year male, left side hematoma, ICA injection. You can see the ophthalmic artery is visualized, but not very well visualized. This is left external carotid artery injection. This is middle meningeal artery. This is frontal trunk. This is posterior trunk. So this is posterior trunk. This is anterior trunk. When we advanced the catheter, we found there is a falcine artery going to the falx, and these are the other branches. There's some blush here. So we cannot do embolization from here. There's a falcine artery which may have correlates to the ophthalmic artery. So we have to place our microcatheter distally. So this microcatheter was placed distally, so no more falcine artery is ring now. Embolized with the particles again 150 to 250 micron. And this is after embolization. Distal branches have gone, but still this falcine artery is very much visible. Then we want to go to the posterior branch and embolize the posterior division. So this is pre and this is the post. The middle meningeal artery is visible up to here. So again it is beyond the safety point. And again we can see this falcine artery is intact. So that is about middle meningeal artery embolization in the subdural hematoma. Then second is meningeal tumors. So meningioma are present at the skull vault or base of skull, and the middle meningeal artery is the major dural supply to the canine meningioma. So these are the various locations: olfactory groove, supracellular, crinoid, sphenoid wing, cavernous sinus, petroclavicle, cerebropontine angle, cerebral convexity, tentorial, foramen magnum, parasagittal, falcine, convexity, intraventricular. So these are the various common sites for the meningioma. So depending on the type of blood supply, we can divide this meningioma into 4 types. Either they are exclusive supply from the external carotid artery. Type 2 is mixed supply. So it has ICA and ECA supply, but predominantly supply from the external carotid artery. Type 3 is again mixed supply, but predominantly supply from the internal carotid artery. And the type 4 is exclusive supply from the internal carotid artery. So this is the 4 type of the supply present in the meningioma cases. So if there is anterior cranial fossa, the blood supply mainly comes from the middle meningeal artery. Then it comes from the anterior falcine artery from the ophthalmic artery. In the middle cranial fossa, the supply comes from the middle meningeal artery and the dural branches of the petrous and the cavernous ICA. In the posterior fossa, it is a rarely middle meningeal artery. Its supply usually comes from the posterior meningeal artery of the vertebral artery and other external carotid artery branches. So this is the artery supply depending on the location. Convexity, mainly middle meningeal artery or an artery of anterior falx. There is usually branch of ophthalmic artery. Then sphenoid wing may have supply for the middle meningeal artery and meningohypophyseal trunk. Tentorial is supplied meningioma are supplied by the tentorial artery of Bernowski and Caginelli, then by the middle meningeal artery. Olfactory groove meningioma mainly supplied by the ophthalmic artery, anterior and posterior ethmoidal artery and middle meningeal artery. Paracellular and petroclavicular meningioma are supplied by the middle meningeal artery or accessory meningeal arteries. And the posterior fossa are not commonly supplied, but they can be supplied by the middle meningeal artery, also along with ascending pharyngeal, occipital, vertebral artery and the cerebral arteries. Meningioma has classical angiographic pattern, what we say is a sunburst pattern. And the pile vessel embolization should be taken with a very caution because there may be chances of deficit. And we must remember anastomosis between medial meningeal artery and intracranial artery to avoid complications. After embolization, the surgery can be done within 7 days of embolization. So this is one of the case, 63-year female with left sphenoid wing meningioma. So tumor on the left side, you can see this marked shifting over the middle cerebral artery. There is tenting of the middle cerebral artery, so it is pushed upward. There is shifting of the anterocerebral artery also. This is the blus, the main supply from the recurrent ophthalmic artery. You can see there is a classical sunburst appearance. This is the left external carotid injection. So this is middle meningeal artery, and we can see the frontal branch, anterior branch is supplied to the tumor. There is the intermedullary artery which is also supplying to the, giving this vascular bus. So we went through the anterior division. We used the particle 50 to 150 micron, and post embolization you can see the artery is almost intact, but this blus has gone. So as far as possible, the particles should go in the capillary bed of the tumor rather than occlusion of the vessel. So this is after embolization through the middle meningeal artery. So this is the pre and post, and there was a significant reduction in the blood loss during surgery. Another case, 10-year female with left frontotemporal meningioma. So here we can see there is no supply from the internal carotid artery branches. This is left internal carotid artery, and you can see there is shifting of the ACA, but there is no blus here. But through the middle meningeal artery, frontal branches, you can see there is a marked tumor blus. This is the venous field, and you can see there is a classical sunburst appearance. So we went through the anterior region. There is no danger synopsis here. We went up to here and placed the PV particle of 50 to 150 micron. This anterior division remained intact, but blus has gone. So this is pre and post. You can see the major branches are intact, but the blus has gone. And it has had for surgeons to blood loss during surgery. So this is pre and post embolization. This is the cerebral mass. Even the posterior fossa masses also can be supplied by the middle meningeal artery. So this was the tumor, and it was supplied from the pica and from by the superior cerebral artery. But when we catheterized the middle meningeal artery, we found that there is a supply from the middle meningeal artery, and there was a supply from the occipital artery. So as I told this previously, that posterior division have anastomosis with the occipital artery. So there was a supply from the middle meningeal artery. So we went through the middle meningeal artery, both divisions. So these are the vascular supply here. So we went microcatheter in the posterior division, in the parieto-occipital branch. We could not reach here, so we have embolized from here only. And this is the after parieto-occipital branch embolization. Still it was supplied by the petrosal segment. So again we went to this division also. And this is embolization after. And in this case, we also went through the pica as well as superior cerebral artery, and the tumor was significant reduction in the tumor blus here. So this is pre. This is from the occipital artery. We went to the occipital artery again for the embolization. So this is after post embolization. Sorry, this is the post embolization. The tumor blus has significantly reduced. The last case, of course, this is different kind of chapters, but what I want to say that middle meningeal artery is very good for embolization with the dural fistula. So if you want, because you know dural fistula is supplied by the multiple branches. So if you get one single medial meningeal artery, that is enough for curing the fistula. So transarterial embolization through medial meningeal artery has been successful option for the dural arteriovenous fistula. Robust medial meningeal artery is the best predictor of successful embolization because it has a long state and large diameter. So I'm sharing one of the case where the medial meningeal artery cured the fistula. So this is 49-year male with headache, and we know this tentorial branch of superior cerebral artery supplying the fistula. This is the right external carotid artery injection. This is the medial meningeal artery supplying the fistula as well as occipital artery. This is right external carotid artery injection, and we can see the medial meningeal artery is supplying to the fistula. Left external carotid artery injection is a good supply to the dural fistula. So first we went to the right occipital artery but could not embolize nicely. So we went to the left medial meningeal artery posterior division. Place the squid 12, and this is the glue cast. So if you get very good one medial meningeal artery, you can cure the fistula rather than going to the different branches. So this is the post embolization. Now the fistula is not flowing from the left external carotid artery run. This is the right external carotid artery run. Fistula is not flowing. And these are the vertebral injection run. And you can see the fistula is cured now. So take home is medial meningeal artery. It is important to understand the anatomic variation for safe embolization in case of chronic SDH, meningoma, dural arterial fistula. And another indication for medial meningeal embolization is chronic migraine or chronic intractable headaches. It is important not to embolize from the position proximal or near foramen spinosum, and it's most important to preserve this orbital connection because it may have connection with the ophthalmic artery, and sometimes you may danger this ophthalmic artery because of this dangerous anastomosis. So anything above the orbital roof is always safe. And thank you for patience.